Hello everyone, my name is Shelby Filial, and today we're going to be learning about capnography, or as we often call it, end-tidal. Capnography is a tool that helps us see how a patient is breathing, how their blood is circulating, and even how their body is making energy. So, what is capnography? Capnography is pretty simple actually. It measures how much carbon dioxide or CO2 a person is breathing out. Capnography is measured using tubing that is connected to a nasal cannula or even directly into an endotracheal tube. Capnography gives us two things to look at, which is what we're going to learn about today: a number and a shape, or a waveform pattern. And this tells us how the CO2 is moving out of the lungs. So let's break that down a little bit. Starting off with the number, or the EtCO2. This tells us how much carbon dioxide is coming out at the end of each breath. We measure this in millimeters of mercury, which is a unit of gas pressure pushing through liquid and membranes. Think of the number as the how much part. Then next is the shape. Like I said before, it is like a waveform pattern. It's just a little graph that goes up and down with every breath so we can watch. This shape shows us how the CO2 is leaving the lungs as the person is breathing out. If the shape looks a little weird, like a shark fin or a flat line, or if it's really high or really low, this could tell us that there's something wrong with the airway, the lungs, or just breathing in general. Think of the waveform as the coming out part, how it's coming out. And we're going to look at some examples here soon. As we all know, every breath has two main parts: our inhalation, or breathing in, and our exhalation, our breathing out. As we exhale, the air that comes out first is mostly from our upper airways, the mouth, the trachea, the bronchi. This air is also called dead space air. And that just means that it hasn't been down to the alveoli yet, so this air contains very little CO2 at this point. The air that comes out last, at the end of the exhalation, it does come from the alveoli deep in the lungs. The alveoli down here is where gas exchange happens. So where that blood releases the CO2 into all the air sacs. This air has the highest concentration of CO2 of the whole breath. So why is it called end tidal? Well, the end tidal part just means that it's the end of the tidal breath. That's where it's measured. And a tidal breath is just a normal, gentle in and out breath. So why do we monitor CO2? Every time our cells make energy, they give off CO2. That CO2 then travels into the blood, to the lungs, and then is exhaled. So while we're watching CO2, we're actually watching three things at one time: breathing, blood flow, and metabolism. Let's talk about a little bit of history. Most people don't know that capnography has actually been around for decades. Starting in the 1700s, Scottish chemist Joseph Black described a gas that he called fixed air, which is now what we know as carbon dioxide, or CO2. This discovery kind of laid the foundation for understanding gases in respiration. It wasn't until the late 1800s that scientists realized that exhaled breath contained more CO2 than inhaled air, and that this gas was a product of metabolism. Skip forward to the 1940s through 1960s. This is whenever clinical measures began. So anesthesiologists began routinely using capnography to ensure that patients were ventilating properly under anesthesia. The 1970s is whenever that waveform capnography began being displayed. So machines became more accurate and began displaying the waveform and not just the number. At this point, clinicians could see breath by breath shapes with the number, which helped identify an airway obstruction or ventilatory problems along with the number. The 1980s and the 1990s is whenever capnography moved into EMS and critical care like we see today. We use it mostly for endotracheal tube placement or critical ventilation monitoring. The standard of care in the OR and EMS guidelines in many countries recommended continuous waveform capnography for all intubated patients, not only in the operating room, but also during EMS transport. In the 2000s, capnography devices began to improve. We have our mainstream sensors and our side stream sampling. So our mainstream sensors are where the sensor is placed directly into the airway circuit. So this is faster and more accurate at the airway with little to no delay. The side stream sampling is allowed to be used in non-intubated patients via a nasal cannula, which is lightweight and flexible in most settings. Hospitals and EMS increasingly integrated capnography into the ventilators and monitors that we use today. In about 2010, the AHA, or American Heart Association guidelines emphasized ETCO2 monitoring during CPR. Capnography became a critical tool for assessing the quality of chest compressions, and we will discuss that a little bit more in a couple slides. So before we look at an actual waveform, let's go over some numbers, just some normal values. A normal end-tidal CO2, or EtCO2, is 35 to 45 millimeters of mercury. If your number is reading higher than 45, it's showing hypercapnia. And this just means that the patient isn't ventilating well. This could be from an overdose, hypoventilation, respiratory depression. If the number is lower than 35, this is noting hypocapnia, which means that your patient could be hyperventilating or is not perfusing well, like in shock or sepsis or metabolic acidosis. Sometimes we see maybe the line suddenly disappears. This could be likely that the airway is blocked or maybe our tube has become dislodged. We will see some examples of these graphs coming up. So let's break down just a normal waveform pattern as you see here. A normal waveform pattern has 4 phases. So our phase 1, our inspiratory baseline, this is the start of exhalation. So air is coming from that upper airway, like the nose, the mouth, the trachea. Dead space air, like we called it before, it has not reached that alveoli yet. Our phase 2, our expiratory upstroke. So exhalation is continuing, and that air from the alveoli is starting to mix with our dead space air, causing that upstroke that you see. Phase 3, the alveolar plateau. Exhalation is coming now from the alveoli, so gas exchange is occurring. This should show a flat or a slightly raising, high and steady slope. The end-tidal is actually measured at the end of this phase right here, which is the highest point before inhalation begins. Which brings us to phase 0, also known as phase 4, which is our inspiratory downstroke. This is the beginning of inhalation. So fresh air is coming back into the lungs, the waveform falls back down to 0, and then we start over again. Capnography helps us in 4 big ways. Our placement, so is our tube in the correct spot? Ventilation, is the patient breathing effectively or ventilating effectively? Perfusion, is the blood circulating like it's supposed to? And metabolism, what is going on at the cellular level? So placement, confirming the tube is in the right place. When we intubate, our most important question, is the tube in the trachea or is it in the esophagus? Continuous waveform capnography is now considered the gold standard for confirming correct tube placement. If the tube is in the trachea, you'll see that consistent rectangular waveform with every breath, like we saw in the previous slide. If the tube, though, is in the esophagus, we might see 1 or 2 blips of CO2 just from swallowed air. Think of it as a false positive, and then it'll most likely flatline. This makes waveform capnography much more reliable than like a color changing device because it proves not only the initial placement, but also ongoing placement throughout care. Ventilation. Ventilation shows how well the patient is blowing off that CO2. So a normal EtCO2, like we talked about before, is 35 to 45. If the end tidal is higher than 45, this means hypoventilation. So our patient is not breathing enough. CO2 is building up. You might see this in overdoses, head injury, severe COPD, anaphylaxis. If the end tidal CO2 is lower than 35, this could mean hyperventilation. So again, that patient is just breathing too fast or too deep to blow off that CO2. You might see this in anxiety, pain, or DKA, diabetic ketoacidosis. Capnography gives us this information breath by breath in real time, much faster than pulse oximetry can. Perfusion, so reflecting blood circulation. For CO2 to show up in the lungs, it has to travel in the blood. So from the tissues, through the heart, into the lungs. If circulation is poor, less CO2 reaches the lungs, therefore the end tidal will drop. In shock, a low end tidal reflects poor perfusion. As we treat it with fluids, it's improving that circulation, that end tidal will rise. And clues about metabolism. Every time our cells make energy, they produce CO2 as a byproduct, like I mentioned before. So if metabolism goes up, like in a fever or seizures, CO2 production increases and that end tidal rises. If metabolism goes down, like in hypothermia, cardiac arrest, CO2 production decreases and that end tidal will fall. As we discussed a little bit before, during CPR, end tidal tells us how good our compressions are. So when the heart isn't pumping well, CO2 cannot get back to the lungs. Therefore, that end tidal will drop. Low values mean that chest compressions are not moving enough blood. So a higher end tidal means better perfusion. Rule of thumb, end tidal less than 10 millimeters of mercury after about 20 minutes of CPR might indicate poor survival odds. Greater than 20 millimeters of mercury is a good sign of good blood flow and circulation to the lungs. We might see a sudden spike in the graph, like on this slide right here, and this often means that we have gained ROSC, or return of spontaneous circulation, which means that the heart has restarted. Capnography gives us a window into a patient's perfusion status and not just their breathing. This is why it's super valuable during resuscitation efforts. Looking a little bit further into metabolic issues like DKA, or diabetic ketoacidosis, patients breathe fast and deep to blow off that CO2. So that end tidal might read very low, sometimes below 25 even. This is a huge clue even before lab tests can come back and tell us, for us to diagnose and start to treat patients with suspected metabolic acidosis. In patients who are septic, end tidal is often low at first because the circulation is poor. So once fluids improve that perfusion, that end tidal will rise. I have heard many people ask the difference between capnography and pulse ox because some people just aren't sure. So let's talk about that a little bit, do a quick comparison. SpO2, or the pulse ox, measures oxygenation. So it just shows us how much oxygen is in the blood. They use the little light through a finger, ear, toe to show us the estimate of hemoglobin carrying oxygen around. The downfall of SpO2 is that it can lag. It often takes approximately 1 to 2 minutes to show changes after a patient has stopped breathing because blood oxygen just doesn't drop right away. It often can also look normal in things like hyperventilation, carbon monoxide poisoning, or even just due to dark colored nail polish. End tidal CO2, though, is ventilation. So it shows us how well that patient is breathing that CO2 out by measuring the gas from the airway. This shows us immediate feedback with every breath. So we work them together and show us the full picture of what's happening. A couple graphs here. When a patient has breathing problems, the waveform often changes. So we'll look at a couple. The shark fin. This could indicate bronchospasms or an airway obstruction. So in patients with COPD or asthma or anaphylaxis, the wave looks like a shark fin, as you see here, because the airways are tight. So prolonged gas mixing and slow exhalation causes that slanted shark fin-like slope in that first chart right there. If the waveform suddenly disappears, this is what I was talking about earlier, where the airway might be blocked, causing apnea, or maybe the the tube is dislodged, so we need to look at it. A little bit more about hyperventilation and hypoventilation, like we talked about. With anxiety or panic attacks, the patient might be breathing too fast or hyperventilating, so they're blowing off that CO2. That number is going to drop below. And then in overdoses or head injuries, patients are breathing slow, hypoventilating, so that CO2 is going to build up and that number is going to rise. Capnography is good about letting us see these problems in real time. Like all tools, the capnography is not perfect. Our mainstream sensors can add weight to the tube, to the airway, clog with secretions, and then our side stream systems can also clog with like moisture. It can dilute the sample, causing a waveform delay. And of course, it's not as crisp as a mainstream, though still a good tool. Capnography is obviously not perfect because nothing is, but it is one of the most powerful tools that we have. So, just to wrap up, capnography, I think, is a very underappreciated tool. Shows us breathing, circulation, and metabolism in real time. So, both the number and the waveform matter. Always pair in-title readings with your clinical assessment and the waveform shape. Capnography, my thing to say about it is use it early, use it continuously, and use it for more than just intubation. Use it for all airway, breathing, circulation problems that you might have. It can tell you so much more at the root. So this is how capnography saves lives. Thank you so much. I hope you guys learned at least something. If you have any questions at all, feel free to reach out, and I hope that everybody has a great week.